Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through reproductive health pharmacology, beginning with female and then moving on to male. We're going to start with birth control, which is in pharmacology terms called oral contraceptive or OCP. This is talking your pill birth control. It's also known as COC for combined oral contraceptive because it's a combination of an estrogen and a progesterone. There are at least 30 different drugs that fall into this class, but all of them have an estrogen component and a progesterone component. The mechanism of action of how these work is that they prevent ovulation, which is needed to become pregnant, by suppressing LH, which is luteinizing hormone. What do we use this medication for? Well, we use it obviously for contraception to prevent pregnancy. We also use it for acne and to reduce the risk of endometrial and ovarian cancer. It does have a few off-label uses, such as to regulate periods, to suppress menstruation, as well as to treat PCOS or polycystic ovarian syndrome. This medication, this whole class of medication, does have a major adverse effect, and you're for sure going to see this on a pharmacology exam, and that is that it is known to cause blood clots. So patients who are already at risk of blood clots, such as someone who sits around all day like a truck driver, someone who's overweight, someone who has a history of blood clots, someone who's a smoker, those would all be contraindications or relative contraindications. Just think about it carefully before giving it to a patient. I will tell you, if someone's a smoker or has a history of blood clots, almost always this would be officially contraindicated. The other ones would just be considered high risk. Withdrawal bleeding, just so we understand what people call a period, withdrawal bleeding is bleeding that happens during the hormone-free interval. Okay. When we're talking about hormonal contraceptives, you shouldn't really see this at the RN level, but you may hear the term withdrawal bleeding, and that's what it's called when a person stops taking their standard 28-day pills, 21 pills, and we're going to get into this, but 21 pills have the medication. Then they go through bleeding for 7 days, and then they start taking the pill over again, and their bleeding clears up. That is technically called withdrawal bleeding. Just so you know, if you see that on exam, that's what we're talking about. These drugs do have a black box warning. They can cause a DVT or a thromboembolic event. We talked about this. These pills do come in a 24 or 28-day cycle. They also come in 91 or 365-day cycle. The most common by far is a 21 pills and then 7 placebo pills, which is a 28-day pill pack. So that's going to be 3 weeks of birth control, 7 weeks of a placebo. The placebo sometimes contain iron, sometimes it contains absolutely nothing, and it's just there so that the patient gets used to every single day. I take my pill in the morning, and that's it. They don't forget. They don't have to remember to start over again. The 28-day cycles sometimes come as a 24N4 so that the woman has a shorter period of bleeding. Next, we do have a whole bunch of medications that can interact with birth control, and in almost all cases, it's going to reduce their effectiveness. The standard birth control pill, what we're talking about right now, is considered the most effective method of contraception. It's more than 99% effective at preventing pregnancy, but there are certain medications that if a patient's taken that while taking birth control, it reduces the effectiveness of the birth control. The classic examples of this are the anti-seizure medications and the antibiotics. If a patient's a female of childbearing age and they're taking birth control and they are put on antibiotics or they're put on anti-seizure medications, we do have to educate them, or the provider has to change their medication or their method of contraception because their method of contraception, the birth control, may not work as well. In terms of antibiotics, since that's usually short term, we may recommend a patient to, let's say, use condoms until they get their next period and they're done with their antibiotic. If it's the seizures, then obviously that's almost always going to be a long-term or lifelong medication. So we have to consider what's the best option for the patient. When taking oral contraceptive pills, generally we start within a few days of a new period of new bleeding. We almost always recommend patients to start on a Sunday purely for simplicity's sake. There's no pharmacology behind it, but just to make things simpler for the patient. If they're dead set, they want to start every Tuesday a new pack, that's perfectly fine as well. Patients, when they're first starting birth control, should absolutely be educated to use another method of contraception for the first few days. Usually the first 7 days is what most textbooks say of starting their new birth control regimen. However, some textbooks, I do say, so I don't want to confuse you, some textbooks I've seen say that if a patient starts it as soon as their new period begins, then, or while they're still on their period, then it's okay that the birth control will be effective and they don't need to. I'm going to just put it out there both ways because I've seen it both ways in the textbooks. I'm staying out of the disagreement. If a patient who's taking birth control forgets to take their pill in the morning, they should be educated to just take it whenever they remember throughout the day. Okay, not ideal and should not be their habit, But if they take it every day at 9 a.m. and they don't remember until dinner time, it's fine. Go ahead and take it then. Generally, any other medication, as you should have heard by now in pharmacology, you as an RN are not going to be telling a patient what they should do in the case where they miss their dose. Obviously, if it's 5 minutes, go for it. But anything more than that, please be careful with your license. Don't start giving medical advice. These decisions are sometimes complicated about when a patient should take their missed pill, when they should wait till the next dose, when they should take a half a pill, things like that. Don't get into it. This is one specific case where the textbook is pretty clear that a patient can take this medication throughout the day if they forgot it. Next, we have, and obviously, if a patient becomes pregnant, they do need to immediately stop their medication. I'm going to take this opportunity to tell you again, if a patient calls up that they became pregnant and there's some medication that they're on that maybe isn't good with pregnancy, you should not be making that decision. Tell them, let me get you on the phone with the provider or come into the office. You should not be telling them to stop their medication. Other than this one, if they're taking this medication to prevent pregnancy and they're on and they say they become pregnant, in this one case, I'm going to give you the go ahead, not me personally, but it is standard that over here you can say you can probably stop taking birth control and probably should. Next, progesterone only pill, also known as POP. So this is more commonly known as the mini pill. This is progesterone only. So the previous one was a combination estrogen and progesterone. This is progesterone only. This has a more complicated mechanism of how it works. And this has 4 different mechanisms by how it helps prevent pregnancy. I know that sounds like it's a lot more than the other one, which we just talked about one. However, this is actually a less effective method of birth control. It's still above 90%, but it is less effective than the regular one. The reason we would use this is because this is something that a patient can start immediately after childbirth while breastfeeding versus standard birth control is not recommended during breastfeeding. And this one also does not have the same risk of clots. Plus, as of recently, and we're filming this in mid-2025, as of recently, the last year or so, in some places, this is now available over the counter. So that's a huge benefit to patients that don't have easy access to healthcare. The progesterone only is available over the counter. Why? Because it doesn't have that risk of developing blood clots, which is the primary reason that the standard birth control is by prescription only. A subclass of this, we have medroxyprogesterone. Medroxyprogesterone is a progesterone medication. It is given as a contraceptive, and it's known as Depo-Provera. It's an injection, either IM or sub-Q. There is a PO medroxyprogesterone, but that one is not used for contraception, for preventing pregnancy, so I'm not talking about that one right now. Right now, this one we talk about is used for contraception and abnormal uterine bleeding. It does have a black box warning that can cause cardiac disorders, dementia, and breast cancer. Again, all of those are relatively low risk, but it is enough that it's put on there as a black box warning. Patients are not recommended to be on this for more than 2 years. And taking this by injection increases the patient's risk of bone density loss. Anytime you see that, you should be ready for a test question, something to do with educating the patient to supplement with, anyone? Calcium and vitamin D. Good. Next, we have emergency contraceptives. So emergency contraceptives is what a patient takes, not as their routine birth control, but if they are not on routine birth control and they had unprotected sex and they want to make sure that they don't become pregnant, they can get emergency contraceptive. As of at least 5 or 10 years by now, these medications are available over the counter. So this is going to be Plan B or Plan B one step, or Ella, which is ulipristal. These medications are what's called emergency contraceptive. These interfere with ovulation. These can be taken after unprotected sex. However, they must be taken within the first 3 to 5 days. After 5 days, they're no longer effective at preventing that intercourse from resulting in a pregnancy. This is most effective the sooner it's taken. So even though it is effective up to 3 to 5 days, it still should be taken as soon as possible after unprotected sex. This medication is significantly less effective in a patient that has a high BMI. That does not mean you should double the dose or anything like that. It just means keep in mind, if you're going to be using this, that this is not as effective. I should say in general, this taking Plan B is a Plan B. It is not Plan A because it is not as effective as taking a standard birth control every single day. However, this is, I don't know the exact numbers. I think it's something like 94% effective. So it doesn't have that 99% that regular birth control does, but within the time frame, it is pretty high up there as being pretty effective at preventing pregnancy. This will not cause an abortion. So if someone's pregnant and takes this medication, this will not cause an abortion. Do not do that. Obviously, it can be severely harmful to the baby, but this cannot be used to induce an abortion. And like I already mentioned, this does not require a prescription in the United States. To induce an abortion, I'm not going to go into that in this lecture, and most nursing schools don't, but just so you know the drugs, if a patient is getting an abortion and they're doing it pharmacologically, in the United States, we have 2 medications that we use to induce an abortion. One is mifepristone, and one is misoprostol. Mifepristone is a steroid. It ends in ONE, just like prednisone and hydrocortisone. It's a steroid. It's also known as RU486. It's been around for decades. So that medication is used to induce an abortion. This is what they do at clinics that induce abortions. And the second medication that almost always is given together with this is misoprostol. If you've already watched the GI pharmacology lecture, we discussed misoprostol because it has a completely separate use in helping with peptic ulcer disease. However, it is one of the two drugs of the combo drug pack, the mifepristone and the misoprostol, that we use in the United States to pharmacologically induce an abortion. Next, let's go through some general pregnancy principles. So far we talked about preventing pregnancy. Now let's talk about some general pharmacology principles related to pregnancy. First of all, every single patient who is pregnant should be recommended to take iron and folic acid supplements, even when they begin planning conception, not when they come to visit that they just found out that they've tested positive for pregnancy. If you're counseling a patient and they say they're planning to try to have a baby, they should immediately begin taking iron and folic acid supplements. And the reason for that is because that folic acid is really important in the first 3 weeks of the embryo development. And at that point, most people don't even know that they're pregnant yet. So we definitely recommend they should start taking it as soon as they begin trying to become pregnant. Technically, most of the textbooks say 30 days or 90 days before they even try to become pregnant, they should already be taking this. Not saying for a second you can't try to become pregnant if you're going to start taking it today, but just keep that in mind for your patient education. Next, once a patient is pregnant, they are recommended to take the prenatal vitamins and obviously get regular health care. That is part of your job to counsel patients on this, and this could end up on a pharmacology exam. Next, let's talk through some medications that patients will be taking not related to their pregnancy, but sort of related to their pregnancy. So we know that nausea in pregnancy is very common. It's called hyperemesis gravidarum. And the go-to recommendation pharmacologically for that is going to be pyridoxine, which is vitamin B6, and doxylamine, which you may recognize as an antihistamine. Those two, and they are available together in a single pill by prescription, but those two are actually each available over the counter. Those are recommended, first-line recommendations for a female who's pregnant and is having nausea related to pregnancy. If those don't work, then we get into the other medications, depending if you've watched the GI lecture or not. We have medications like Zofran or Reglan, things like that. Some OBs say those are safe in pregnancy. Some say they're not. I'm staying out of it. We discuss it more in the GI lecture. Next, we have our first-line medication for heartburn in pregnancy, which is, again, another common issue, is going to be an antacid. That's going to be preferred over some of the other medications that we discuss, again, in the GI lecture for that. But when you talk about antacids, avoid the magnesium and the sodium bicarbonate ones. So there are other ones like Tums, calcium carbonate. So just remember the magnesium and the sodium bicarb ones are not the ones that are recommended. Next, we have constipation, another GI-related issue with pregnancy. And the recommendation here is actually to stay away from medication and use things like fiber, the bulk-forming laxatives, and to increase fiber, increase fluid, and increase activity. If they do need medication, docusate sodium is generally considered safe in pregnancy. If a patient has a routine headache or something like that in pregnancy, acetaminophen is definitely pretty universally preferred over ibuprofen or any of the NSAIDs. And finally, if a patient has preeclampsia, and I've seen some of the test banks that get a little bit tricky with this, they'll just put in that the patient has maybe some edema or maybe some hypertension, things like that, and it wants you to pick up on the fact that the patient has preeclampsia. If they do have preeclampsia, that is a blood pressure problem primarily, and that's going to be treated with methyl-dopa, with hydralazine, and with beta blockers, all of which are discussed in the hypertension lecture. So now we talked about preventing pregnancy. We talked a little bit overview about once you're pregnant. Let's talk about becoming pregnant. So the drug class, the first one we have is ovulation stimulant. This is to help people become pregnant. The first drug we're going to talk about is clomiphene, which is known as Clomid. This drug causes growth in the ovarian follicle by stimulating the release of FSH and LH. What is it used to do? It's used to induce ovulation. Generally, when a patient takes this medication, the ovulation happens within 5 to 10 days of finishing the medication. So let's talk about that. So the patient is going to take the pill starting on day 5 of their cycle. So if their bleeding started today, on day 5, they're going to start taking the clomiphene. They're going to take it for 5 days. And then starting at 5 days after that, they're recommended to have intercourse every day or every other day for the next 5 days. So it's 5, 5, and 5. First 5 days are they're bleeding. Second 5 days, they're taking the medication. Then wait 5 days and then start having sex at least every day, every other day for the next 5 days until after the final dose. Do keep in mind you need to educate patients that are taking this, that this increases their chance of having a multiple gestation, meaning twins, triplets, etc. Also, I should clarify, even though I put all this on here, I put it on here because it confused a lot of people about when to start taking it and all that. But at the end of the day, I have never seen this on a nursing exam, pharmacology exam, about when to take it, so don't stress that. Next, this drug may be called a SERM. Some of the nursing textbooks call it a SERM. I put it as an ovulation stimulant. That's what most of them do, but I did see some of them listed as a SERM. It certainly is both of them. I'm not disagreeing with either one of these. Letrozole is another drug that is also used for this exact same thing. In fact, these are the two drugs that are used for patients that are suffering from infertility, that are unable to get pregnant. We either use clomiphene to induce ovulation, to stimulate follicular growth, or we use letrozole to stimulate follicular growth. Neither of these are going to make you ovulate, but they're both going to prep the egg for ovulation. Both of these also are not recommended to be used for more than roughly 6 months. If the patient can't use it for 6 months, I've seen some of the books say 12 months. In real life, the OBs I know, they usually limit it to 6 months, 6 cycles. And if it didn't work at that point, we would move on to counseling about IVF or IUI or something like that, which we're not going to get into in a pharmacology lecture. Now, again, those are to stimulate the egg, to stimulate follicular growth. To actually induce ovulation is a different drug called HCG. HCG is, many of you may recognize, is the test that we do on patients to see if they are pregnant or not. But that is actually a medication we can give. We can give it by IM injection. And usually then that will stimulate ovulation. And usually the OB will be able to tell you exactly when after the injection you're going to have ovulation, to know the exact window to try to have sex to result in a pregnancy. Next, let's talk about a tocolytic. Tocolytic, so now the moms become pregnant, and now we have an issue with preterm labor. Preterm labor is where mom went into labor. She's having contractions prior to what we consider ideal, which is generally 36 weeks. Anything after 36 weeks is pretty rare for us to try to stop that. But before 36 weeks, especially once we hit viability at about 24 weeks, so 24 to 36 weeks, if mom goes into labor and starts to have contractions, this is where we would give a tocolytic to try and stop pregnancy. To try and stop delivery. What drugs are we talking about? The 4 primary drugs that we use for tocolytics are terbutaline, nifedipine, magnesium, and indomethacin. All of these drugs also have other uses, and all of these drugs are discussed elsewhere in pharmacology, but let's go through it real quick. Terbutaline relaxes the smooth muscle, so that stops the contractions. Nifedipine relaxes the calcium. It's a calcium channel blocker. Calcium is used for muscle contraction. Again, relaxes the uterus. Magnesium is a smooth muscle relaxant, so again, relaxes the uterus to prevent those contractions. Indomethacin has a little bit of a complicated way that it works, but it inhibits prostaglandin synthesis, which is related to what stimulates contractions, and therefore it blocks that. It reduces those contractions. 4 different drugs, 4 different ways that they work, but they all have the same end result, that their goal is to stop contractions so the baby can keep developing inside mom. The indications for these drugs is to prevent preterm labor, as we talked about. A lot of times we use this for 2 primary reasons. One is to give us a little bit more time for, hopefully the contractions just stop, and mom usually goes on bed rest at that point, but mom makes it till their full term, 36, 38 weeks. On a secondary note, if that's not going to be our goal, then our goal would often be with giving these drugs one of 2 things: either to delay delivery maybe another day or 2, so that we could give babies steroids to develop them a little bit more if we know that, whether we like it or not, baby's going to be here in the next few days and we're not ready for it yet. Or the other thing, we may do this just to delay a few hours until mom and baby can get to, or mom at this point holding baby or with baby inside, can get to a facility that can hold it. We want the baby to be able to get to the highest level NICU, which to the best of my knowledge is a level 4 NICU is the highest level. That's able to take care of everything all the way down to about 24 weeks. So sometimes we're going to give this just to stall for a few hours because mom showed up at any hospital that doesn't have that really high level NICU, and we want to get them to the higher level NICU. I'm not going to go into the details here, but just so you understand, NICUs have 4 different levels. The highest level is going to be a 4. The lowest level is going to be a 1. If you're familiar with trauma centers, it's the opposite, but because trauma centers, 1 is the highest. Anyways, NICUs different at different levels, and this, I be honest, I don't know the numbers by heart, but the different levels NICUs can handle moms delivering at certain ages. So a level 4 is the highest that can handle a mom delivering all the way down to 24 weeks, but the other levels can handle maybe 32, 34, 36 weeks, 28 weeks, something like that. Each one has its own cutoff about where it's capable of handling a baby delivered at that point, because we know at each week of development what the issues will be and what we need to be able to handle the complications that come from preterm delivery. Just so you know, as a nursing student, roughly at 24 weeks, if a baby is born in a high-level NICU, the baby has already at 24 weeks, amazing to have almost a 50 or roughly a 50% survival rate, which is unbelievable. At 28 weeks, again, assuming they're at the highest level NICU or at an appropriate level NICU for 28 weeks, which might be a level 3, I'm not sure, a 3 or 4, that child already has a 90% survival rate. So really outstanding. Tocolytics can only be used up to 48 hours. So again, either it works and mom completely stops contractions and they can go about the next few days and weeks of having baby develop further, or if we're going to be delivering, at least it buys us time to get the baby to the hospital, or sometimes to get the baby some steroids to develop those lungs a little bit better before baby does come, even if they're coming early. So now let's move on. Mom is now in labor, and now the next drug we have is oxytocin. Oxytocin is used both to induce labor and to control bleeding after labor. Oxytocin stimulates uterine contractions. The tocolytics prevent uterine contractions. Pitocin or oxytocin stimulates uterine contractions, which is what gets baby out. What do we use this for? To induce labor, to get mom to start pushing, or to get the uterus to start pushing baby out. We also use this after the baby is born, because now mom is bleeding out from the uterus. So we have the uterus contract, and it sort of contracts down on itself to sort of clamp its own bleeding. And that's how everyone knows already, if someone's bleeding, we put pressure on it. That's sort of how we get to put pressure on the uterus, by getting the uterus to clamp down on itself. Now, I will tell you, this drug is officially used for the second thing I just mentioned, after mom delivers, to be able to go ahead and to clamp down the uterus so that it can put pressure on itself to stop bleeding. However, it is used extremely widely for the induction of labor, but that's not an actual official use of this drug. This is purely a fun fact. You're not going to get tested on it, other than the fact that this actually has a black box warning that you shouldn't use it to induce labor, even though we do that literally every single day. But it is an off-label use for it. Please do educate mom that this medication very quickly, in a matter of about a minute, is going to make the contractions increase in strength from whatever it was. We always go up very slowly on this medication when we're inducing labor. Postpartum, we can give it much quicker, but when we're giving it to induce labor, we go up very slowly, because with every dose increase we do, mom is going to have stronger and stronger contractions. That can be really dramatic, really painful. Please educate your patient accordingly. That's the end of pregnancy. Let's move on to the last little bit of women's health, and then we'll move on to men's health. Estrogen replacement is a drug class. This has conjugated estrogen. This is exactly what it sounds like. It's an estrogen replacement. What do we use it for? The symptoms of menopause, such as hot flashes, vaginal dryness, etc., as well as we also use this to treat breast cancer. The black box warning here is that it increases your risk of endometrial and breast cancer, of cardiovascular disease, and of dementia. It does have a whole list of side effects. Because it's an estrogen, you better remember that it increases your risk of blood clots. That is such a common test question. This medication is definitely teratogenic. You can't take it during pregnancy. Also, if you're dealing with a patient who's postmenopause, please educate the patient that calcium and vitamin D is almost universally recommended for this patient. Next, that is the end of women's health. Next, let's move on to men's health. So men's health, we start with androgen, which is testosterone. Testosterone, you should remember from anatomy and physiology, is a hormone that's in both males and females. Everyone has this. Obviously, it's significantly higher in men. The mechanism of action here is that it produces anabolic and androgenic effects, such as muscle growth, male sex characteristics, etc. Male sex characteristics, you should recognize that's deepening of the voice, increased muscle mass, things like that. What do we use it for? Delayed puberty, hypogonadism, and as hormone replacement therapy. These do have a black box warning for hypertension, that it can cause hypertension, and also virilization in women and children. That means if a woman or child is exposed to this drug, they may develop those male sex characteristics. If it's a female or if it's a child, in either case, that can be a negative effect. Next, we have that this medication comes in a variety of modalities, a bunch of different ways that the patient can receive this medication. I have seen a number of test questions on this in different test banks on male reproductive health, so please make sure you know this list. Next, this medication does have side effects. It's not really the medication, it's the testosterone, has side effects of insomnia, aggressive behavior, and polycythemia. This does require regular monitoring of a patient's blood levels, of the prostate, and obviously of testosterone. This is a controlled substance. It's not a narcotic, so anyone who thought up until now that controlled substance and narcotic is the same thing, they're not, because this is a controlled substance. Next, we're going to talk about BPH, benign prostatic hyperplasia. Benign prostatic hyperplasia is a disease. The most common symptom of this, obviously it affects only men, but the most common symptom of this is that the patient has frequency of urination. If they're constantly having to go to the bathroom, they have an inability to have a good steady stream of urine and the inability to maintain a good steady stream of urine. And because of that, they're having to go to the bathroom a whole lot, not to be confused with a UTI. Now, when a patient is being treated for this, we have two first-line drug classes. The first one are the alpha blockers. We've discussed alpha blockers extensively in two previous lectures, or I don't know what order you're watching these in, but in two other lectures. So I'm not going to go into it too deep over here, but let's do it real quick. We have a bunch of different subclasses of alpha blockers. For the purpose of BPH, we're going to talk about tamsulosin, which is known as Flomax, and that is most commonly the drug that we would be giving for BPH. It works by relaxing the prostate, so the prostate is no longer pushing on the urethra, so the patient is able to have a normal urine stream. This does have an adverse effect of orthostatic hypotension along with reflex tachycardia. Plus, this drug is very well known that it can cause erectile dysfunction. So if you're giving this to a patient, please educate them that if they do develop erectile dysfunction, to please alert the provider so that they can be given a medication for that. We don't want to just ignore that. That's a big quality of life issue. Next drug class we have are the 5-alpha reductase inhibitors. Now, it's interesting because I've seen some guidelines that say this is the first go-to drug for BPH, and I've seen some that say the one we just finished, the tamsulosin, is the first go-to drug. Again, I'm staying out of it. I just want you to know I'm just going to say they're both first-line drugs because they are. Just depends who you ask. How does this work? This one works in reducing prostate growth, again, so that the prostate is not inhibiting the urine flow through the urethra as much as it was previously. What do we use this for? We use this for BPH. It's also used for male pattern baldness. And again, this also has that side effect of sexual dysfunction that it can cause ED. Speaking of ED, that's our next disease on here, our next drug class, the PDE5 inhibitors, phosphodiesterase 5 inhibitors. And these are very famously Viagra, Cialis, Levitra, sildenafil, tadalafil, and vardenafil. These work by causing smooth muscle relaxation, which increases blood flow to the corpus cavernosum so that the male is able to get an erection. What do we use this for? We use this for ED, plus not all of these, but some of these can also be used for pulmonary artery hypertension. What are the side effects? The side effects are headache, hypotension, priapism, which is a unwanted and long-lasting erection, and hearing and vision issues. The hypotension and the headache, you should recognize that those are both also the side effects of nitroglycerin. Nitroglycerin is a drug that if you already watched our angina lecture or our heart failure lecture, we discussed it there. It's a vasodilator and it can cause headache and hypotension. And it is very, very similar to Viagra. Therefore, these drugs cannot be given together. I mentioned that both under the nitroglycerin, that it can't be given with these, and I'm mentioning it here now, that these cannot be given with nitroglycerin. Tadalafil, specifically, even though it is used for erectile dysfunction, it's also used to treat BPH that we just finished talking about a few minutes ago. This medication, it can also be given to treat the it is often prescribed to address the side effect of erectile dysfunction because there's so many drugs that can cause erectile dysfunction. We obviously just mentioned alpha blockers, plus also beta blockers, a lot of your antidepressants, alcohol, benzos, all of these can cause erectile dysfunction. Finally, depending on your school, whether they're going to discuss the STD medications over here versus an infectious disease, I don't really know how much they're going to cover this in the RN level at all to match up the specific STD with the specific medication. But I did list it here really quick just in case you have to know it. I'm not going to go through it. I'm going to leave it for you. All of these drugs are discussed in depth in our infectious disease video. If you have any questions, please reach out. Our references are listed here. Subscribe to our channel, please. Like our videos and have a great day.